So those, how many entrepreneurs do we have here who are looking for money? All right, so look at their faces and just grab them before you leave. So a lot of them invest, they're angel investors. I'll just tell you about some programs here. And they could be your mentors, advisors, as well as industry contacts. And the second group is members. Membership is open to everyone for it's about 75 cents a day, $150 a year, and you get wine, you get nice spicy food, your system gets cleaned up by next day. So you just cover the cost within a month, right? It's a real detox process here. So please become members, those who are not members, and that's how we are able to organize these programs. And then the another constituencies are sponsors. Number of them, a lot of large companies, like we have our sponsor Stan sitting here right here from Morgan Stanley, and then a number of other organizations like SAP, Microsoft, Cisco's, and all VC firms, law firms who support this organization. Basically, all the kind of ecosystem of this whole entrepreneurship in Silicon Valley. Then the last and not the least, actually, the fourth constituencies are volunteers, like I said. So volunteers are a huge part of what we do. Now, what we do is programs around fostering entrepreneurship. So one key flagship program is TiECon, which we do in the middle of May. Which is, how many of you have been to TiECons? Oh, great. So, in fact, I went to TiECon in 1996. That's how I ended up running into an angel investor, and my company got funded, and then 3 years later it was acquired by Novell, and that's why, I'm here volunteering. So it's just, from what I got and just to give back. So then, so if you haven't been there, please go to one of the TiECons. It's a really good electrifying experience. Then other programs we do are industry specific, like this one, life sciences. So we pick up the major ones, like where a lot of entrepreneurial activity is going on in the Bay Area, like life sciences, mobile, big data, software-defined infrastructure. In fact, 2 days ago we had an event called My Story, where we featured Nicira co-founder Martin Casado, whose company was bought by VMware, which is revolutionizing this whole concept called software-defined networking. And then we have these inspirational ones like Thai Women's Forum and My Story, which is a monthly program. And then there's VC 101, where we have VC and 7-8 companies who are selected. They pitch in front of them. So if you can apply for that, look at our website. And another 2 programs, new programs comparatively to other programs, are Thai Angels, which started 2 years ago. And it's a monthly event where if you're looking for seed funding and you're up to half to 1 million, you can go through our website and apply for it. It's a 3-step process. You get screened. If you get 8 companies are invited to get screened again, and then 3 are presented in front of this Thai Angels monthly meeting, where you have about 60 to 80 investors who come, and then you might get funded. And then another program which we just started, as you can see those cubes there, is called Thai Launchpad. It's focused towards the enterprise software companies, I would say, mostly. So if you're interested, again, check out our website. So with that, what I would like to do is just introduce our co-chair, Praveen Shah, who is co-chair for life sciences, and he's been a Thai volunteer for over 5 years or so, and co-chair for the last 2 years, and he's been really instrumental. I mean, this panel couldn't have been here without him. He himself is a successful entrepreneur, and right now he's CEO of a company called DocsWalks, another health informatics company, and I'm sure he would be happy to talk about it. So with that, let's give a big round of applause to all these volunteers, all these panelists who have been able to take their time to be here. We really appreciate it.
Welcome, folks, and thanks for the wonderful intro, Naveen. All of you guys are here to, hear from the panelists, so I'm going to keep this brief. What we've done today is a mix of practitioners, technology providers, solution integrators on the panel, and a mix of engineers, entrepreneurs, and investors in the audience. So we'll keep this as a more of a discussion, first within the panelists themselves, and later on with a Q&A with the audience. And to set it up, each speaker will first go through a few slides. And Justin, who's Chief Innovation Officer of Hearst. Ramesh, how do we get the PowerPoint back? PowerPoint? So anyway, Justin is the Chief Innovation Officer for healthcare at Hearst Business Media. And while we bring the PowerPoints up, I'm going to hand over to him and can explain his background. Yeah, so I'm just handing it over to Justin.
Thanks, Praveen. And thank you to all of you for having us here for a lovely evening, joining you and this wonderful organization that Praveen's been telling me about for so long. I'm Dr. Justin Graham. I currently am the Chief Innovation Officer for Healthcare for the Hearst Corporation. You may have heard of the Hearst Corporation from our other products like Oprah Magazine or Arts and Entertainment or Lifetime. But what I do has nothing to do with magazines or TV stations. The Hearst Corporation also owns a number of healthcare businesses that are in the healthcare clinical decision support and clinical content space, providing software and tools that help clinicians use electronic health records and do their jobs. And I get to be an innovator within that organization. It's a lot of fun. My background is that I'm an infectious disease physician by training. I still practice, and I've also have training in medical informatics and have been working in the healthcare IT space for 15 years in a variety of roles, primarily helping physicians treat patients using electronic medical records. It's great to be here tonight. I just was curious if I could ask you guys to be the first ones up, because we'd like to know a little bit more about our audience here, since none of the four of us have been here before. How many people in the audience are healthcare professionals with a clinical degree of some kind? Okay, we've got one, maybe two. How many people here in the audience work in the healthcare industry? Okay, we've got a handful. How many people in here are technologists? Majority of our audience. And how many people are in the investing side or the financial side of the industry? Handful there. And who have I missed? Okay, I got most of the other group. So primarily, this is not an audience of healthcare practitioners, so we'll avoid all of the medical talk and jargon and keep it simple. We actually have a wonderful panel here for you tonight that represents three key aspects of how you might apply tools looking at data and big data, as they often say, in the healthcare domain. We have Jonathan Palma, who is the medical director for analytics at Lucile Packard Children's Hospital at Stanford, who will talk to us from looking at big data analytics from the provider side, directly from the hospital and physician side, taking care of patients directly. We have Darren Schulte, who's the president of Apixio, an analytics startup that focuses on payer analytics, thinking about things from how maximizing reimbursement and looking at the payer side, the insurance side of the business. And we have Scott Clark, who's the VP and General Manager of Sama. Hope I pronounced that right, Scott. A large analytics company that has a number of big data projects and big data products underway, but he looks at big data from the perspective of the healthcare consumer. So we've got three aspects of big data as it applies to the triangle, really, of healthcare. And without any further ado, I'd like to ask Jonathan to introduce himself and his background and tell us a little bit more about what's going on at Packard.
Sounds good. Thanks, Justin. I don't know if I steal this one. Thanks, Justin. I'm John. I'm going to make my way over to the podium as I introduce myself so I can go through a couple of the slides that I've prepared. So as Justin suggested, I spend half of my time being medical director of analytics at Packard Children's Hospital, and the other half of my time in the clinical world, as well as a newborn intensive care physician. And so I've been at Packard for about 9 years at this point, and actually did all my clinical training there, and also got a master's in biomedical informatics during my time there, and that's kind of what led to this dual role in my job with analytics, which has been fabulous. So what I like to do is just share a couple of stories with you today that have kind of informed our approach to making use of the abundance of data we're collecting as part of our electronic health record. The first story, I guess what I'd like to say first is that most of the analytics work we've done up to this point at Packard has really been sort of retrospective and descriptive, and it has been pretty mind-blowing to our practitioners and folks throughout the organization who have never had access to these data before. But we're also working on pilot projects that are a little more innovative and hopefully will ultimately change the way we take care of patients for the better, and that's what these stories hopefully will illustrate today. So the first brief story is about this girl here. Well, not actually this girl, that would be a HIPAA violation of patient privacy, but a girl much like this one who's a 13-year-old patient with a disorder called lupus, an autoimmune disorder. And she was admitted to the hospital with complications of her lupus and critically ill condition with pancreatitis and renal problems. And all of these problems contribute to an increased risk of clotting in patients like her. So we have a really great pediatric nephrologist. We're blessed to have, I think, 6 or so pediatric nephrologists at Packard Children's, where there are some states in the nation that have 0. So the rheumatologist on service at the time, her name was Jenny Frankovich. So she started thinking about this patient and said, well, this kid sounds like they're at increased risk of clotting. We don't usually give these children anti-clotting medications, but maybe we should do it in this case. So like any good evidence-based physician, she went to the literature and tried to find evidence about what you should do in these situations. Unfortunately, her search didn't really reveal anything pertinent to her exact situation. So she did the next best thing, which is go start talking to her partners in the division of rheumatology. Talked to the first partner, told them the situation, and they said, oh yeah, absolutely, this kid is at great risk for clotting. I would definitely give them anti-clotting medications. And they said, oh, okay, sounds good. Went to her second colleague, and the second colleague said, absolutely not. There's no way I'd do that. It's way too risky. So that's when Jenny did something that, to our knowledge, hadn't really been done before. She looked at a cohort of lupus patients, about 100 pediatric lupus patients from our research data warehouse, to figure out what their risk of clotting was when they had these conditions, like the pancreatitis and the kidney condition that this patient had. She found out that this child was probably at somewhere between a 12 to 14 times increased relative risk of having a clotting disorder. So based on that information, she decided to give the patient anti-clotting medication. And so we don't really know if that was the right decision, honestly. The patient didn't end up having any clotting complications, and there were no bad effects of the anticoagulation, which can sometimes be a risky medicine. But we do know she sort of made the best data-driven decision she could at the time. And so that has really informed one of the areas that we're working on a pilot project at Packard, which is around text analytics. Because really what Dr. Frankovich had to do was, when she identified this cohort of patients, she had to go back to the text documents to define, which patients were the ones with the pancreas problem and what were the outcomes for those patients. So we've entered into a pilot project to better structure our semi-structured and unstructured text data for the purposes of similarity matching and finding cohorts of patients and defining the outcomes for those patients. So what Jenny did in this paper that was published in New England Journal of Medicine can be done in a more automated fashion in the future for making decisions. And I've been really humbled in my, I'm into my second year now on faculty in the newborn intensive care unit. And there are so many questions, I'm sure you guys can attest to this, that come up every day in the hospital for which there are not answers in the doctor books and not answers in the literature. So I think there's a real opportunity to make use of some of the sort of frozen data in the documents that we're collecting. This second story, it touches a little bit closer to my clinical area. So this is a very premature newborn infant. And we're often faced with a situation of a child being born and needing to counsel the parents on what we think is going to happen with this baby in the future, what are the risks of them passing away, and what are the risks of disability. And so this source of data that was used on a research basis in the last couple of years at Stanford was the physiologic monitor, the monitor vital signs data. So by looking at the streams of data from the Philips monitors at Packard, this group of researchers, which included some neonatologists and some folks from the computer science department, they were able to look at the first few hours of life of these physiologic data and predict late morbidities for patients that could occur days or weeks or even potentially months later, with higher accuracy than some of the more standard risk assessment scores used in neonatology. So while we're not using this in practice today, I think we are collecting loads of this data that right now are sitting on a hard drive in the basement of the biomed area. But it has also informed future research projects. So we're doing several projects in the cardiovascular intensive care unit and pediatric intensive care unit as well, to look at these streams of data and try to predict outcomes like deterioration for a patient or a change in the patient's course, so we can act more quickly and take care of them more appropriately. So those are the sort of two stories I wanted to share that relate to two sources of sort of big, or what I sometimes call it, uncertain data in healthcare. And I kind of stole that from John Kelly of IBM Research. That's the first place I heard him describe it as uncertain data. That are really, I think, potential sources of improved decision making. Right now we have a lot of questions, and there's a lot more data available to us to come up with answers, and I think that's part of the promise of big data in healthcare. Thank you.
Thanks, Jonathan. Our next speaker is Darren Schulte, who is the president of Apixio. He'll be telling you a little bit more what they're doing in the payer space.
Great, thank you. So anyway, while we get the slides deck, thanks everybody for coming out tonight. I'm Darren Schulte, I'm the president of Apixio. I'm an internist by training, but for the last 10 years I made a career in the entrepreneurial space, really taking clinical analytics, providing solutions in various different companies for both payers and providers. What I want to talk about today, there's a lot about big data and in healthcare. Certainly there's a lot of hype. What I'm trying to provide for you certainly is, Jonathan provided excellent stories on the provider side, but I'd like to do is kind of what we're trying to do for a particular use case and for payment of healthcare. Apixio is a 3-year-old company based in San Mateo. We basically provide solutions using big data analytics for risk-bearing healthcare entities, and we do so for purposes of risk assessment, revenue, and better approaches to managing clinical and financial risk. So let's start with this. So a lot of people will say healthcare is different, healthcare is different. So if you look at any chart, any one of your charts in any one of the clinical documentation, let's assume your physician's using electronic medical records. Thanks to stimulus dollars, 50% of physicians across the United States are. So if you look at the ecosystem of data in any one of your charts, 90% of your data is going to be text in some way, shape, or form. Only a sliver is coded for purposes of billing or coded for purposes of some other transactional processes that go on in the healthcare system. Most of it is then unstructured, typewritten or handwritten in the past, and hopefully it's a thing of the past because I can't read my own scribble scrabble, much less anybody else's. So let's think about a mid-sized health system now trying to figure out what do I do with all that unstructured data and try to make use of it and sense of it. And for the technologists in the room, you could probably sort of certainly appreciate that, this is one of the customers we recently implemented. Just as an example, 200,000 patients, 5 years of historic data, and that data resides on an electronic health record system. That's 10 terabytes. Sort of not a big deal, but it is a big deal when you think of the variety of data and operating on it. So if you look at the machine hours of time just to compute the data, all of healthcare to date in analytics, and most of what's been done has been done on coded or billing data for analytics, and that takes just 200 machine hours. Not a big deal. Any one of your laptops can do that work for purposes of figuring out some question you want to get answered. When you're now operating on data and tagging it for purposes of trying to figure out something in all that unstructured data, as Jonathan was describing, for purposes of provider-oriented use cases or payer, now we're talking of tens of thousands of hours of machine time to do something with it. And when you're talking about now data that's been scanned, because the physician still talks about sending faxes between one another, and it's now in some scanned documents, and you have to read it in some way. That takes a lot of time and effort to tag it and figure out how to do it and create indexes. So you need big computers, parallel processes, and you need to figure out how to work on all that variety of data. All right, step one, lots of data, now digitized, unstructured, 90%. Step two, I'm going to take you through a little bit about healthcare payment. We'll be okay, don't worry. We'll be all right. We're going to hopefully get away from a fee-for-service world, because fee-for-service, I'm paying you for everything you do for me, is reasons why healthcare costs are way out of control. So now we have hopefully some mechanism with the Affordable Care Act and Obamacare in which now we're going to determine how to incentivize payment, or at least thinking about payment, based on value that's being provided, not just how many services you're giving. But what we need to do, if we're going to pay based on value, I'm going to pay for you to provide care for a patient, but I'm providing you one payment. You get to pay to determine how to take care of that patient, but I'm not going to pay for everything you do. But if I pay you based on value, I'm going to pay you based on how sick the patient is. Makes sense, right? I don't want to pay you less money if the patient's sicker. Guess what? You got to determine how sick the patient is. It's called risk assessment. I won't take you through all the policy implications, but now if I have to determine how sick you are, pay accordingly, I got to go through 90% of all that data that's text, figure out how sick you are. The doctors know how sick you are, the organization has no awareness, and the payers have no awareness. This is a scale problem, and through Obamacare, and we can take you through all the specifics later on if you're interested, 60 to 80 million insured patients across the United States will need to have some way of determining their burden of illness or risk assessment, and you got to go into all that unstructured data. That's a big data problem. And people don't know what's coming. It's coming. The only ways in which you get around that today, guess what? A lot of healthcare is done today with a lot of labor. Manual processes of going to the chart, figuring out what's there, writing it down, not going to scale. Any technologist will tell you, not scalable. We need technology to enable the basics of understanding what's in the chart for both assessing and managing risk. Okay. Step 3. Let's apply what's done outside of healthcare and bring it to healthcare. Novel, right? Before healthcare records were digitized, there was no reason to bring what now is done on the internet every single day. To understand and mine the text on the internet for retail, for consumer, for banking, or whatever, and make sense of it. Guess what? Now healthcare records are liberated. They're digitized. Hallelujah. Now we can bring what's being done outside of healthcare into healthcare. So what do? We can apply knowledge graphs, figure out how all these concepts that are figured out within the healthcare record relate to one another. Big problem, right? How's it done in healthcare today? Manual. We can apply knowledge graphs the way Google does on the web. We can apply machine learning to understand how to recognize information that's in all these different varieties, train computers and algorithms to learn how all these data represent one another, use pattern analysis, all these techniques that are used outside of healthcare, bring it to a patient record, create a mathematical representation of the patient's experience, a phenotypic picture, multidimensional matrix, and provide analytics on it at scale with parallel computing processes. Sophisticated text mining to enable you to understand that this patient in this particular note was noted by the clinician to have diabetes properly controlled. Not just diabetes, but it's properly controlled, because that's going to be different for you and your cost implications than diabetes that's not properly controlled. Guess what? It's buried in the text. I, as a physician, know it. Jonathan knows I'm taking care of patients. Justin knows taking care of patients. The organization doesn't know it. We're shifting towards performance-based payment. That's the way we're going to control health across the United States. I'm not going to pay for what you do. I'm going to pay for the value you provide. In order to do that, we got to understand and manage how sick you are, meaning how much are you going to cost in the future? How much are you likely to have outcomes that are good or bad in the future? It resides in text data, and it's not going to change. You got to mine it, analyze it in large volumes, in all the variety and color in which it lives, and you got to provide at scale some results that enables you to operate on that. And the proper setting of risk for value-based payment is going to enable us to have control over costs, but also this is the ultimate big data problem in healthcare. And healthcare is one of the largest segments in the United States, so it's the largest big data problem. Thank you.
Thanks, Darren. And our final panelist is Scott Clark from VP of SAMA, who's going to talk to us about bringing big data to the consumer side.
Thanks. I'm Scott Clark. Recently joined SAMA, and my background is in life sciences technology in a number of different venues. And as Justin just said, the learnings from other industries actually apply very nicely now as we go forward in healthcare and life sciences. And SAMA does that. We focus on a number of vertical segments, including insurance, high tech, financial services, consumer products, and life sciences and healthcare, which is the practice that I'm heading up. And the learnings that we've gotten from those other industries are now being applied into life sciences and healthcare in a unique way. So what I want to talk about today is how we are taking our technology framework, which was developed to be able to support all of those different verticals, and apply it to a specific area in terms of patient satisfaction. So I'm going to be representing sort of the patient side of things. Okay, there's only two other choices of buttons to push. Oh, there we go. First point is there's an increasing rise in the use of social media in healthcare. Depending on different data, you get different surveys in terms of that. The point of this slide is that 2 years ago, about 30%, 29% of consumers said that they would use social media and share their own personal experiences within how they were dealt with at various provider sites and healthcare situations, moving to 33% just a year later. The most recent survey I just saw for half of this year, it's now up to about 40%. The interesting thing for me is as you look at the demographic around that, you would predict that the younger population, so the 15 through 24-year-olds, that's just how they communicate now, so they're going to do it. The interesting statistic for me was that saying that actually over 65% of those people between 55 and above will also be using the internet to comment on, access, think about, and look for how they're going to get their health care. So it becomes an increasing opportunity / challenge for healthcare providers to know that that's there. As you know, social media data is all text-based, unstructured. So we've got the same problem that you just described in terms of how we have to look at the data, how we have to analyze it, etc. The other point is that it's raising the bar in terms of the responsiveness that a provider needs to be able to do in order to deal with problems that are identified, experiences that are shared. And so you have a number of providers now launching initiatives in terms of looking at healthcare, the social media data to really understand, ideally to prevent problems or have to deal with, hype that's out there that goes viral on something that turns out to be false. So what we did in conjunction with a major hospital is looked at, are there ways that we can look at patient satisfaction and prospectively identify triggers that influence it, both positively so that we can do those things, but also adversely so that we can avoid those things. One of the provisions of the Affordable Care Act is that eventually reimbursement is going to be based on these survey results, patient satisfaction survey results, so the financial impact is significant. But more importantly, it's how can a provider increase, because the overall goal is to increase the quality of care that they're giving to patients, and obviously that's the broader motive. But there's also the financial motive that says, the better I do on a patient survey, the better I perform, the more I'm going to get reimbursed. Well, those are retrospective analyses. What can we do prospectively to be able to do that? And so we were able to provide the analytics capability to take a look at a number of different sources of data. My talk right now is primarily on social media, but it also involves all the other kinds of things. The the slide that I hid, we say it's about 80% unstructured, so it's, I'm going to change that to 90 because that actually plays to our strengths more. But the kinds of things that you're looking at are external sources, social media, as well as government surveys, rankings, those kinds of things. All kinds of internal unstructured data, the text-based data that come in a number of ways. And then the small portion of it that is, in fact, structured data that you can then code to, etc. What we did is we looked and took the unstructured data, again, I'm talking about social media today, so this is our mapping here, to try to understand what the patient voice was saying. We looked at it in 2 dimensions. We looked at it in terms of a patient sentiment, and we looked at it in terms of how that correlates or how that relates to the more structured data. Could we identify and infer opportunities for improvement based on actual survey results and then try to tie it back and map it to social media at the time that it occurred? Again, this prospective look at how you would do that. The idea is if we could identify root causes, if we could compare, the other piece that we added was a ability to compare amongst your competitors. So gauging hospital system to hospital system, geographically, etc., as a way to be able to tie that into how we can leverage our strengths as a provider and as the consumer, how they are starting to look at things in terms of the way that they are making selections around healthcare. So what we did, we analyzed patient satisfaction both from a standpoint of polarity and of emotion. I just put a screenshot there. The significant piece of it is that we have this ability to identify what are the triggers. What are those things that trigger either a very positive consumer experience, a patient experience, a trigger that may have a negative one. But more importantly, we were looking at the non-obvious ones. The ones that, yeah, if you have to wait for 5 hours, that's probably not a good experience in a hospital. The joke was one of the people that we're working with said that one of the hospital providers at a local baseball stadium would show you their wait time, because and it was supposed to be a positive incentive, and it said wait time 12 minutes, 14 minutes. About the 5th inning, it got up to 3 hours, and somebody didn't have the right algorithm that says if it gets above a certain point, just shut the thing down and flash to the next slide. So some of them are obvious. The ones that are more non-obvious are the ones that we are trying to uncover through the use of our analytics techniques. Our findings, we have found some of the interesting but non-obvious correlations. There are things that really influence patient experience, and even more, maybe more importantly, why patients score hospital setting or their healthcare provider at a 9 or a 10. There is some correlations to certain events that occur within the patient experience that directly tie to that. And our customer was very interested in that and realized that there are opportunities now to take those triggers to initiate acts that will allow them to continue to improve that over time. Second is that emotion is a big deal. I skipped over the slide where it said that if you have a bad experience or a good experience, how likely you are to talk about it in social media. They're very highly correlative in terms of bad emotion. We have fear, we have anger as emotions that we score. Those directly tie, as you would suspect, to negative scores. But you also have some that are interesting, things like surprise, that actually turn out to tend to score positively in certain areas, but not all areas. So these are the kinds of insights we were able to get. One of the things that we found, and again, our background and experience was sort of a horizontal view of things where we applied algorithms that work in high tech, in insurance, etc. There's tuning that needs to go on to be able to understand how to do that within healthcare. One of the interesting ones for me is the question of how you deal with sarcasm. So how do you score that? And there's a lot of sarcastic comments on these about, my hospital was great, and then they proceed to trash it for however time. So if your algorithm says great equals good, you may be missing something there. And so we've been working to tune those algorithms to be able to refine them and get them in the context that makes sense. It's early days. I think we'd all agree that there's a lot of opportunity here. So all of you entrepreneurs out there that are interested in this space, it's growing. It's going to be big. It's maybe not quite as big today, but we were talking about things like sensors and monitors and those kinds of things. We're going to get big data really fast in terms of volume and velocity, whereas today we have it primarily in variety. And then the last point is a plug I want to give for one of my employees who was involved in this project and got the idea that could we improve healthcare overall by looking at things like Twitter feeds. We were talking about how you might be able to see, epidemic based on what's happening in Twitter. And so he started an open group forum. So if you actually Google Twitter healthcare analysis, his group, and it's an open group started by new college graduates from SAMA, have that. I would encourage you to join. It's gone viral in some ways in terms of the people that are joining, but it's all about how do we improve the outcomes for healthcare. And so now, in closing, I have a question for you. The first person who answers it correctly gets a really fancy prize. Unfortunately, we're a small company, so it's not that great, but it is kind of a combo pen/marker. So, what do you think the most tweeted about disease is?
Cancer.
No?
Diabetes.
No?
Sexual disease.
No? 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 I guess one of you guys want to guess? Hazard a guess? It was again, it's non-obvious, but when you think about it, it makes sense, and this is going to be, again, the power going forward. So here, you can have the pen since you sat in the front row. I always try to reward people who sit up front. It's autism. Which actually, when you think about it, kind of makes sense because it tends to be looked about and not much is understood about it yet, and so, but it's a disease that is gaining in prevalence and understanding, and it turns out that a lot of people tweet about it. So thank you very much.
Thank you. That was fascinating. I actually didn't know that at all.
We didn't
that's
either
great.
until we.
Well, yeah, amazing what you've learned. Well, I'm intrigued by one of the bullets on your slide, and I thought since we have an audience largely made up of technologists who may not have healthcare background, you mentioned that the algorithms that you were working with that came from other big data projects outside of healthcare, retail, insurance, or finance, don't apply in healthcare. And so I'd like each of you actually to take a minute to just talk a little bit about what makes healthcare data different. If you're a big data expert in another field and you come into healthcare, what do you need to know?
So,
I'm good at buttons.
is that better?
The light went on.
So they actually work but need to be tuned. So the natural language processing algorithms and those kinds of things, you can do cluster analysis, you can do nearest neighbor analysis, you can build the neural network and things like that. Looking at that and understanding and scoring what matters, that's the part that becomes healthcare specific. So that's where you have to start looking at, what does it mean if, in the case of social media, this statement is made, and then how does it correlate back to another statement? Maybe a better example for this is work that we've done in the area of key opinion leader on the life sciences side of our practice, where how do you influence someone in terms of making a medical decision, and so what do you value more? Patents and publications, or speaking engagements, or numbers of patients they see, or number of patients they refer? Those are all things that, depending on who you are, you may have different values to, and so those are the kinds of things that we have to start then tuning.
So do you find that when you're looking at healthcare data out on Twitter that people are publicly posting, that there's a certain level of the data that may be opaque or hidden from you because people are concealing it because they don't want to display their health conditions, as opposed to, I'll tweet about my airline experience because I don't care that people know what airline I was on, but they may not want to talk about their hospitalization.
We were surprised, in a way, and again, I don't know what the actual number of hidden ones are because they're hidden, but we were surprised at how open people actually are in terms of expressing medical conditions. I probably wouldn't want to do that myself, but it is amazing how many people do that. And you have a lot of these patient registries and things like that where people of similar, have a similar condition want to find out about it. But it also now has gone beyond that to where it just becomes another topic of discussion in social media. We look at Facebook and you can see a lot. The challenge is, as Jonathan was talking about, that you can't. How do you avoid violating HIPAA and those kinds of things in terms of the stuff that when people self-disclose and things like that. So that's going to be an interesting topic going forward.
Darren, why don't you go ahead?
Sure. So one thing that, there's many challenges. One that we find is, you would think this is pretty simple, but representation of a concept. So let's take the way that someone would describe somebody's heart function. Okay, there are quantitative and qualitative means, all in which would describe someone's heart function. So representing the different terms and ways and phrases that really speak to one concept in healthcare is a ginormous problem. In healthcare, kind of one way of talking about is interoperability. How am I going to take one organization's means of representing that concept, one physician's means, one specialty's means, not just to mention what one coding structure is going to use to represent, say, diabetes or heart function, but the way in which it's going to be captured in text and how that can be synonymous with another means of capturing that text and how that's going to differ among different training. That's actually a hard problem. And if you don't get at that problem to start, you can't layer your knowledge, because that's sort of the basis in which you're going to figure out from all these different variety and data sources, how do you represent that one concept and do so effectively to really capture that as the basis as your starting point. So that one problem in healthcare in terms of representation of a concept is one that can be very challenging.
Well, but surely there's a standard.
That's sarcasm.
Hey, sorry, did you pick up the sarcasm?
And my response to that is, I love standards because there's so many of them.
That's right. Particularly in healthcare. We could do a whole panel session on that.
I was going to add a third way in which there's a challenge. I mean, many of the algorithms you might want to apply are the same, but at least from some of my work in the master's program, it seems like getting to the point to apply the algorithm is really hard. I mean, even the structured data in healthcare is very messy. So the data pre-processing that has to go on presents a challenge. If you're looking at a vital signs stream data from a monitor, there are times when, for instance, a baby is picked up by mom and being patted on the back, and the monitor reads, this kid is having a heart attack, and that's not happening. So you can't just feed that into an algorithm. Even if you have that monitor hooked up to your EMR and are recording a few events every couple of hours into the EMR. If it was at a time when the back was being patted, it might say the heart rate is 250. And that's wrong. I mean, you can't just feed that into an algorithm. So I just think the data are very, when we were talking about clinical data, are very messy.
Now, if you were just getting started, you're an entrepreneur looking to get involved in the healthcare data space, you all are well along on your various projects, but what are the places that you think where there are opportunities in healthcare data analytics?
I guess I'll start since I have this microphone
Yes,
now.
you won the lottery.
I think one common thread through all of our talks is we all talked about text as being a major source of big data in healthcare. So certainly one of my interests is to enable better decision making for practitioners in healthcare. But I think what Darren talked about applies to both spaces. Being able to represent a patient based on the unstructured data that's collected, the 80 to 90% of unstructured data collected as part of their medical record, presents a huge opportunity. I think the challenge that Darren mentioned as well is these multiple representations and mapping them to sort of unifying concepts is certainly an area of opportunity as well.
Do you think that we're going to see more and more moves toward structured documentation as we see more implementations of electronic health records, or do you think we're still going to have unstructured data in the future?
I think that it's going to be more semi-structured. So for instance, we're at Packard Children's Hospital, we are implementing our second electronic health record this next year. And it's been interesting to see how different divisions and departments have decided to collect their data. The obstetrics department, for example, is really interested in generating clinical research from the data they're collecting. So they're taking an approach where you do your clinical documentation in more of a structured way. And while that's going to be great for doing analysis on the back end, I'm not sure that all the obstetricians aren't going to revolt at the clinical workflow that's required to collect it in that way. But what I could see happening is sort of real-time analytics occurring at the time that you're dictating a note or writing a note that suggests concepts to you. You know, is this the concept you're trying to capture? So you can sort of annotate your unstructured document at the time you're creating it so that the person creating it is the one actually saying what concept they're trying to get across.
How about you, Darren? If you were starting over, where would you go?
Right. So in healthcare, as in any industry, first I would follow the money. So just follow the money. So here's one thing that happens in healthcare that is a perfect opportunity for entrepreneurs. So most everything that's done in healthcare is manual. People. We know from other industries that that's not scalable, and that creates a lot of inefficiencies, both on the operating cost side and your ability to do anything done in any kind of scale. So follow the money and technology-enabled processes that take us away from a lot of what I call in healthcare, we throw bodies at the problem at any turn. And I guess just to throw in a little controversy of why not, I would never want a physician to structure any note. Never. I just wouldn't. Why? I want it to be, because you lose information, it's a lossy system. When you go from some sort of narrative that has richness and context to something that is coded in a more structure, it is a lossy system. And you are going to miss lots of information that is going to affect patients' care and patients' lives. So let physicians be physicians, let them do what they're going to do, but follow the money and figure out how I can take an inefficient, broken, manual, costly, unbelievably backwards process and take technology and make it better. But if you don't follow the money, you'll be lost, because it's still about showing return. There's a lot of costs in the system. Reduce the cost at every turn, and people are still worried about cost, don't get me wrong. It's certainly we want to be about patient care, and you can have your cake and eat it too, but there's so much cost and waste in the system. Somebody said 30% or more of healthcare is wasted. That's like the starting point. The starting point, right? So as payment structures change, we're going to sort of wring that out a little bit, right? Because we won't get the whole, I'm going to give you a CT scan because I just bought one, right? That happens. But nonetheless, there's still going to be a lot of inefficiency. So I'd say it's a perfect opportunity for entrepreneurship. But if you don't follow the money, you'll get crushed, because you're going to, get sort of lost in, tons of people doing, lots of different things in a very noisy and crowded space.
One question.
Oh, in the back.
So just to go one step lower down, where do you see the most inefficiencies in these business processes? Is it the insurance companies? Is it the providers, the clinics or the hospitals? Or do you think we can go to the consumer?
Yes.
Yes, and. So yes, and sort of, okay, here's the future, right? Here's the biggest cost center that healthcare is going to have and have to face: hospitals. Hospitals are the biggest cost center, and under value-based payment, they will continue to be an absolute cost center where money goes and never to be returned. So anything in a hospital, if you go there these days, if you read anything about the way hospitals have functioned, it's like 17,000 businesses in one. You cannot make it an efficient system when you're having literally 17,000 workflows being done. Doing surgery is a lot different than caring for a patient who's coming in for pneumonia. Totally different process. You know, it's like if any of you are fans of Clay Christensen, go read what he has to say about Innovator's Dilemma and how you have to take a hospital system, an absolutely broken cost center where, you know, when you're sick, don't go to a hospital. But, you know, it's where money goes to, you know, vanish. So, really, take care of that, and in a network in which there's capitation, or value-based payment, which means I'm going to get on the hook for all your dollars, get in at it, figure out how to get that system better equipped, and you'll be able to flourish. One example of how you'll be able to flourish. Because the CFO as a hospital is a bad place to be in your career.
Yeah, there are massive inefficiencies in every single step of the healthcare process, and they've all been protected by the perverse business model that pervades healthcare in this country. And despite the recent changes brought on by legislation and ACA and Obamacare, there are still going to be massive inefficiencies that are put in place and held in place by protected interest. And like Darren, I'd strongly recommend you read the book, The Innovator's Prescription by Clayton Christensen, where he just goes and knocks down every single actor in the healthcare system and talks about how someone can come up from behind and disrupt them because the business models don't make any sense.
I wanted to add one other area in terms of looking at things and broaden the perspective just a little bit beyond healthcare to include the life sciences space. And that's this whole notion of, depending on how you want to call it, precision medicine or personalized medicine or whatever, there's a lot of opportunity there. And from a data side, it's the data integration of multi-types of data, genomic data, research data, clinical data, outcomes data, payer data, et cetera.